Good evening, everyone. So my next topic of the video, which I'm going to discuss with you, is on diseases related to bladder, urinary bladder. And before I start my video, I want to request you, if you like this video and if it is helpful to you, kindly subscribe to my YouTube channel. This is Dr. Nitikan's Pharmacology discussion. So now I'm going to start with bladder pharmacology, or diseases used in the drugs used in the treatment of diseases of urinary bladder. Now, first of all, I want to discuss that urinary bladder is consisting of two muscles, that is the detrusor muscle, and which is present the main muscle in the urinary bladder, and the sphincter contains the trigone. And the contraction of the detrusor muscle is stimulated by M3 receptors, which are present on the detrusor muscle. They cause contraction of the bladder, and the relaxation of the detrusor muscle uh, is by the beta 3 receptors, and these cause the relaxation of the detrusor muscle. And in trigon, there is a presence of alpha 1A receptors, which causes contraction of the trigone. And now I'm going to discuss with you the diseases related to the urinary bladder. These can be divided basically grossly. They can be divided into three types, that is urge incontinence, stress incontinence, and overflow incontinence. So first of all, I will discuss with you urge incontinence. Urge incontinence is the disease in which the patient feels the need to urinate before the proper or the limited filling of the bladder. That is the capacity of the bladder, limited capacity of the bladder filling, which produces the urge. Before that, the patient has feels the urge to void out the urine. And this is also the condition in which there is overactive bladder. The bladder becomes overactive, and there is in urge incontinence is there. The patient repeatedly goes to the bathroom and feels the need to void out the urine. And this is also the known as the diffusal instability. It is overactive bladder, and it is also known as the detrusor instability, in which there is more contraction of the detrusor muscle takes place. So to avoid this urge incontinence, we can give the drugs which block the M3 receptor, which cause the contraction of the bladder, and along with it, we can give the drugs which cause the relaxation of the bladder, that is M3 receptor agonist, and the beta 3 receptor agonist, which causes relaxation of the detrusor muscle. And beta 3 M3 receptor blockers are the anticholinergic drugs. These are the derifenacin, sorifenacin, tolbutadine, and oxybutadine. And the beta 3 receptor agonist is the mirabegron, and it is known by the mnemonic Mera Bladder Gone. So that is mirabegron. And these drugs, these can be known by the topic by the mnemonic, that is makes bladder soft. Makes for mirabegron, D for derifenacin, soft, S for sorifenacin, O for oxybutinin, F for flavoxate, and T for tolbutadine. These are the drugs which cause the relaxation of the urinary bladder, and thus distribution instability uh, can be treated, and overactiveness of the bladder can be treated. The second type of the incontinence which I'm going to discuss with you is the stress incontinence. Stress incontinence is the incontinence in which the patient feels the need to void the urine under stress. Stress can be when there is increased intra-abdominal pressure, can be due to jumping, any exercise, in coughing, in laughing. When the intra-abdominal pressure increases, the patient feels the need to uh, void the urine. And this is basically because of the weakness of the pelvic floor muscles. And so where the treatment is, either we can give the pelvic floor muscle exercises, or we can do the surgery And the one drug which is given for its treatment is only one drug, that is duloxetine, which is the SNRI agonist, can be given as the treatment of the stress incontinence. Now, next is the overflow incontinence. Overflow incontinence is the incontinence in which the bladder fills, uh, keep on filling, bladder keeps on filling uh, above the urge, above the capacity to urge, it keeps on filling, and when it becomes filled up, then the patient needs, the urine quantity increases in the bladder, the patient needs to void the urine. And then this can be also known as the condition of atonic bladder. If there is a loss of tone of the bladder is there, so the drug which can be given to treat the atonic bladder is M3 receptor agonist, uh, in which M3 receptor agonist, which is carbachol or methane call, basically methane call. It will make the contraction of the bladder, and then the overactive, sorry, the atonic bladder get reduced, and there is a contraction of bladder takes place. There is no loss of tone of the bladder then. And another type of the disease which can be due to overflow incontinence is the benign prostatic hypertrophy, which occurs basically due to obstruction in the path of the urine flow, and it can be obstructive, or it can be due to, it is basically obstructive. In the urinary bladder, in the trigone, the prostate is present around the trigone. The prostate size increases outside as well as inside. When it increases inside, there is a narrowing of the lumen of the urethra, and this can lead to obstruction to the outflow of the urine because of stimulation of alpha 1A receptors that causes the contraction of the urethra. The alpha 1 receptors get stimulated, and there is contraction of the urethra, but that is obstructed. So the drugs which can be given to treat this disorder is uh, prazosin and tamsulosin, and this benign prostatic hypertrophy, it causes urinary tension in the patient, and also chronic outflow obstruction can be there in chronic cases. And the drugs are the prazosin and tamsulosin. Tamsulosin is the alpha 1A receptor agonist, basically acting primarily selectively on the alpha 1A receptors, and prazosin, it acts on the alpha 1A and alpha 1B receptors. And when it acts on alpha 1B receptors, it causes vasodilatation of the blood vessels also, which leads to postural hypertension. So the drug now preferred is the tamsulosin, which is selective alpha 1A receptor blocker. And basically, these drugs, they reduce the dynamic component of the benign prostatic hypertrophy. Means urinary outflow will be increased by relaxation of the urethra, the trigone of the urethra, and this action is immediate. The dynamic component is reduced, but static component, which is the size of the prostate, is increased. That can be reduced by giving, the size of the prostate can be reduced by giving the anti-androgens, and the anti-androgen given is 5-alpha reductase inhibitor, that is finasteride we can give. It will lead to decreasing the size of the prostate, and this action, it occurs after taking of the drug. After months, the action will be there, and so these both drugs has to be started in benign prostatic hypertrophy. Immediate action is by the dynamic component, that is the tamsulosin, and the delayed treatment is by the finasteride, which is alpha 5-alpha reductase inhibitor. So that's all for the diseases of the bladder. I hope you understood, and be happy, happy learning. Thank you. Stay safe. Thank you.